Yeah, and I know the Department of State Hospitals is also here. They could come up. Welcome, all of you. So if you could maybe talk a little bit, Mr. Receiver, about an update on the activation at Stockton and also DeWitt.
Sure. Thank you, Senator. The news on the update activity at Stockton is, at this point, uniformly positive. We're moving in the right direction, as Ms. Tosh has already indicated. Essentially, ever since late January, the entire department and my staff as well have been working very closely with staff in CHCF to fix the problems. We started out fixing what we considered to be the most serious and easiest problems to fix, which were the ones that were widely reported back in January, dealing with supply chain issues, making sure that medical equipment was being delivered appropriately to the housing units. That has been completely fixed. Actually, that was fixed about a month and a half ago or so. We're well into, at this point, the reboot, which is essentially going from each one of the housing units one at a time and focusing attention on retraining and reorienting both custody and healthcare staff to make sure that that housing unit runs appropriately. It's already been accomplished in 4 or so of the housing units, and they have a good schedule to complete that within the next couple of months. So care is improving substantially. The prison law office will be visiting the facility in a week or two, maybe. Yeah. And whether I'm right or not, I suspect we'll find out in their report. We'll see what they think we have fixed and what still remains to be fixed. So I'm looking forward to their evaluation. In terms of DeWitt, we have already started moving inmate workers over into DeWitt in order to make sure that we sort of shook out the activation of DeWitt before putting medical or mental health patients over there. That seems to be going very well. We are taking it slower than we did last year. Both Secretary Baird and I agree that part of our problem last year was we had a mentality of we're going to keep going no matter what to hit a deadline at the end of the year. And that was a mistake. And so, for example, now at DeWitt, we've been staging moving more people over there. So we'll have a week where we move some people over, and then we're going to have a quiet week or two. Then we'll move some more people over. So we're doing this more incrementally. And as I think a result, we're avoiding some of the, hey, there's a problem here, but we don't have time to fix it. That we're avoiding that mentality. I believe we're essentially on schedule. The state has submitted to the courts a revised schedule for DeWitt's activation. I've forgotten the date, Diana, for when we think it's done. February, we should have it fully activated. It will house a large number of EOP patients as well as a number of special medical patients. But at this point, things seem to be going very well.
CDCR, what do you think?
So I agree with Mr. Kelso's assessment. I was just out at CHCF about 10 days ago as well, and we initially moved over some workers from CHCF. We have also transferred in some inmates from other institutions to test that as well. And I believe ahead of schedule, we are moving over some dialysis folks over to DeWitt to test out because they need to go over to CHCF to get their dialysis. And so at this point in time, it seems as though DeWitt is on track and we're activating, but we have a schedule that I believe will allow for those pauses, as I had mentioned earlier. Before, with the activation schedule that we had with CHCF, as Clark had mentioned, that those pauses were not built in. It was just like, the next group is coming, the next group is coming, the next group is coming. In the meantime, there's no time to catch your breath if you've noticed a process problem. And so I think with this, we're going to be able to move over those the inmate workers. We brought a lot of inmates over so they could be gold coats to assist us with some of the inmates over at CHCF that need help being pushed in wheelchairs and the like, maybe Red 2 or something like that. And then that will also help us with the movement in between the two institutions. Just to be able to test and, you know, as DAI said, make sure all the toilets flush as well. I mean, the practical applications before we send over medical folks.
Okay. And the Department of State Hospitals, do you have any comments, or what role do you play in all this?
Good afternoon, Madam Chair. Sterling Price, Executive Director for the Department of State Hospitals. Ditto. It's much improved. The supply chain, the processes there, and as they said, in any activation, there are always hiccups. This is a pretty sophisticated facility compared to other facilities in the state, so it would be understandable that we had some difficulties in the beginning, but it is much improved, and from our perspective, things are going very well.
Were you involved in the initial activation?
Yes, I've been there on the project for about 2 years.
Okay. I'm just curious, how do you opening a hospital when there's no rubber gloves?
Well, we had initial supplies of rubber gloves initially. We and the state hospitals also had the ability to procure some of our own supplies as well when the rest of the facility was not able to. So that helped us quite a bit.
And
but we
catheters? Catheters the same?
Well, we don't use those. Those are the medical side. So we don't have some of those medical issues. Many of the supplies that were difficult to obtain, we don't use those directly in our program.
Okay. And I don't know if LAO or Finance have any comments? Okay. So as I understand it, the supply chain issues, which were not identified prior to activation, have been resolved. What kind of training, training issues have been resolved? All I can say is staff was on payroll many months in advance of activation. In September, people knew there were serious problems. It wasn't shut down till February. The answer is we were in a hurry. And I appreciate the pressures that we all feel at different times, just in doing our business with the state. The legislature certainly feels it too. But when it becomes a pattern, so that it's like rubbing chalk on a blackboard for legislators to hear, oh, we found it, we're not going to do it again. I mean, at some point, we're talking about how this was allowed to happen. Because if it's impossible to open a safe hospital with catheters and rubber gloves and towels, somebody needs to go to the governor's office or to the head of CDCR or to the legislature and say we can't open a hospital safely. But I know we've activated prisons since I've been chairing this committee. We usually create quite a substantial time when people are there. It just seems when we're talking about things like rubber gloves, catheters, and hand washing, this is too basic. And so it's very difficult. We're interested in the written procedures that were in place prior to the facility opening, and better advanced planning. I mean, there's no point in asking questions because we understand the answer is we were in a hurry. But I am, as a result of what happened at Mule Creek, which was not an incident involving activation, what steps have been taken since then? You're revising the use of force policy. One of the things we've been talking a lot about here is the difference between following the rules and following the intention. It's a cultural issue. What are you doing anything else so that these kinds of things aren't going to happen again? And any written policies and procedures for the communication between CDCR and medical staff?
Yes, so I will tell you that after the incident at Mule Creek, the secretary did bring all the wardens up here to Sacramento to talk to them specifically and personally about the use of force, and to talk to them about going back to their institutions and talking to the custodial officers and the manager on duty for the day, to, if there is a disagreement between healthcare and custodial officers, to elevate it up. And if they have to elevate it up, the disagreement all the way up to the warden and the CEO to discuss, this is a controlled use of force, there's no immediate need, then that's what needs to be done. And so that's what is outlined in the new use of force policy, and the secretary takes this very, very seriously.
Thank you. Thank you. Are there any comments from the public on this topic? Seeing and hearing none, we'll move on to issue number 5, which is the valley fever issue facing our healthcare system. So, Mr. Receiver, can you give us an update on the incidence of valley fever and the steps that have been taken to reduce its impact?
Yes, thank you, Madam Chair. As a result of a study done by my public health staff a year or so ago now, that study showed that the rates of both valley fever and serious consequences from valley fever, because oftentimes valley fever doesn't result in a serious consequence, but that the rates of those at 2 prisons, Pleasant Valley and Avenal, were significantly, markedly higher than the rates at 6 or 7 other prisons in the southern part of the Central Valley, which is also within the Coxsackie endemic region. As a result of that report, I decided that we were at a point where we had to move out of those 2 prisons a substantial number of inmates who would have been at a significantly heightened risk of serious harm were they to contract Coxsackie. After a fairly quick, given the way court proceedings normally go, a fairly quick court proceeding, Judge Henderson ordered that those moves take place, and working with CDCR's pop management people, within the space of about 2 months or so, it was pretty quick, and there was a deadline on it. I think the court had a 60 or 90-day deadline. But we successfully moved, it's probably 1,300, 1,500 inmates from those 2 prisons. Quite a substantial number of the inmates who had the ability to move out of those prisons decided to stay where they were and waived essentially their right to move. But we did move out successfully then the people who were at greatest risk. We have also since then had a study that was requested by the department, by NIOSH, the Federal Occupational Safety and Health people. I think the committee, I believe, has the results of that study. We are awaiting at this point a final report from the Center for Disease Control, specifically about the incidence of Coxsackie and its serious consequences on inmates. We don't have any time frame for that. The Centers for Disease Control operates on its own time schedule. We do know that the rate of Coxsackie this season is down slightly. We have, though it's too early to tell whether that is just because of seasonal variations. There hasn't been as much rain. There are a variety of factors that can influence this. But we're hopeful that over the next year or 2, as we get a little more data, we'll be able to see that, in fact, this program of moving high-risk individuals out of those 2 prisons has actually had a positive impact. We believe it will. The statistics tell us that it will. The statistics tell us we're going to be saving, a certain number of lives by doing this. But until we see the data results, I'm not willing to say that's going to happen for sure. I think where we are right now is waiting for the Centers for Disease Control to come back with their analysis of the situation.
Okay, CDCR.
I agree with Clark. We received the report from NIOSH, and in the report, we were hoping for a little bit more direction and commitment to give us some guidance from the CDC and NIOSH when the report came out. And just recently, I got an email from I believe the head investigator, saying that they had actually started a blog themselves asking the community several questions that were brought up from CDCR and CCHCS once their report came out. And so they're asking the community at large, and they said that they were left with many questions themselves, and they're asking for feedback from folks about should soil stabilization on prison grounds be continued, at what wind speed should prison yards be closed, is there a role for measuring wind speed and doing environmental sampling, and when should respiratory protection be worn by employees, and what type is appropriate. And I can get the link to this sent to you, Senator. And so I still think that there's still a lot of questions to be answered. In the meantime, we did have some ideas of what we could do. I mean, so even though we didn't get all our answers, we have done some things to help mitigate valley fever. And so we do provide ongoing education to staff regarding symptoms and how to do the mitigation. We do have the approved respirator mask for use by both staff and inmates if they would like it. We changed out the filters to high efficiency filters, installed door sweeps, and we have increased some of our dust mitigation measures that we do out at the institution as far as trying to minimize driving on dirt, installing gravel for folks to drive on, and the like.
Okay. Any comments from the LAO or finance? Okay. I'm wondering, the reports that I've looked at specifically talk about ground cover,
Right.
or soil sealants. Have they been put in place in
So we did do a test pilot at Pleasant Valley, and so we were waiting so we are doing the ground covering, we're doing wetting of the ground, we're doing decomposed granite, so we are doing some of those measures, but we still have not received the definitive answer from CDC on whether or not the soil stabilization measure. And the whole thing was that while you may do the soil, what they said at the exit call that we had with them is while you may do the soil stabilization at the institution, you have all the surrounding area where there is still nothing there. And so, we're trying to do what we can within the housing units with the filters and the door sweeps and the windows, closing them on windy days, doing those mitigation measures.
That may be, but nevertheless, the way the disease operates, as you know, is spores in the air.
Right.
And since it is a closed facility, if you could put the sealants or the ground cover within the closed facility, it would seem to me it would help keep the spores from infecting people.
We did the sealant at one of the institutions. I ordered that about 2011 or 10. I've forgotten which year. And on that one, we actually did have our public health people take a look at the incidence of disease after we'd put the sealant on. And it didn't seem to have an impact upon prevalence.
Okay, maybe you could send us that report.
Sure.
Because again, when we read that the public health report suggested these things, we need to know if it was something that...
and Senator, I mean, apropos of the whole problem there, it remains an issue that has not yet been studied. Why it is that at Calipatria, which is right next door, they don't have this problem.
Coalinga.
Coalinga, I'm sorry. Coalinga. They don't have this problem at Coalinga. I got my C's mixed up. And I suspect it's because it's an air-conditioned facility. And people are indoors. I suspect that's a big factor. But we haven't had a study done to actually, establish that. And there can be other things that influence the incidence of disease. But I appreciate your concerns, and when you read these reports and they say, here are 5 things, okay, why haven't we done all of them?
Right.
I don't disagree with that concern.
Okay.
And frankly, until we could do any of those, it seemed like the best thing to do was just move the high-risk inmates out.
Yeah, but as you indicated, Filipino and African-American inmates are considered at highest risk, but they actually were not moved in any systematic way. You've indicated that, and they haven't been excluded from going to the prison now.
No, they are. They're excluded by policy now.
From being transferred in.
Yes.
Okay, but it took a very long time to get that agreement, but I'm good. It's there now. It's there now. Okay, have all the 8 institutions implemented some type of mitigation? Or is it just Avenal and Pleasant Valley, which are not only
Well, the rules
worst?
about moving inmates apply just to the 2 institutions, but that's because the incidence and prevalence of the disease there is so much higher than at the other institutions. I believe the other institutions also have ongoing measures regarding wearing face masks or other similar issues.
I'm unsure of that answer. I
We
would
should
have
check.
to check.
Okay.
for you.
I would
I
recommend
would
that the
have
state
to
not
for the
build
other
any
end.
more facilities in the hyper-endemic area.
I would concur.
Yeah, I think we would all. That sounds
To
like a
state the
plan.
obvious.
That sounds like a plan.
Yeah.
That we could agree.
Okay. Are there any comments from the public on this matter? Seeing and hearing none, we're ready to move on to the Calpea Janitorial Services BCP. So, again, I'm not sure who presents this proposal. This would be Department of Finance? The receipt, yeah, why don't you present, Mr. Kelso?
I'm going to pass the baton
Okay.
over to Joyce Hale, please, my legislative representative.
So for CalPIA VCP, we are requesting $14.5 million in fiscal year 2013-14 and $19.5 million in 2014-15. And that would add positions to all of our institutions to implement a vocational program whereby we use CalPIA as managers of a program for inmates to clean our healthcare facilities.
Okay, any comments from DOF or LAO? LAO?
Yeah, so we would recommend that the legislature withhold action on this proposal. We do acknowledge that there should be a statewide standard for cleaning the healthcare spaces in the prisons, and that should probably include a higher level of training and oversight than currently occurs. However, the cost of the proposal is very high, $1.38 per square foot. By comparison, Kaiser costs $1.36 per square foot, and San Joaquin General, which has a secure wing where they provide medical care to inmates, costs $1.35 per square foot. So we're concerned that the private entities that pay minimum wage for cleaning services would cost more than CalPIA, which would use inmate labor. We're also concerned that 3/4 of the cost of the contract is wages for civil service employees to provide oversight, training, and audit services. And based on those concerns, we would recommend withholding action. We would also recommend that the legislature require the receiver to report on the cost of the proposal and whether an alternative proposal, either by CalPIA or an outside contractor, could be provided at a lesser cost. For example, it might be possible to use CalPIA, but to have fewer permanent civil service staff assigned to the project.
Thank you. Any comments from Finance?
Clint Kelm, Department of Finance. We would just point out that although the cost of the overall proposal is quite staggering, that I think it's fairly representative of the lack of resources that had been previously dedicated to cleaning healthcare areas, and it might be one of the reasons why that we're in the place where we are, where it's being cited in all the court medical expert reports. The $1.38 versus $1.36 is very different because it's not really an apples-to-apples comparison. A Kaiser is a self-contained facility with several levels. These are, semi-autonomous yards with clinics spread out all over the place with different people providing cleaning in different areas. It's a difficult comparison to make. I think CalPIA actually put together an estimate on a few prisons to see what it would look like to staff just with custodian staff at the institutions, and it looked like it would double, possibly not double, but almost double the cost of the proposal in itself. So we understand that seeing the numbers in itself look fairly high, but we would just point out that I think this is kind of just a lack of resources that have been dedicated over here to that function over time.
So I have a few more things in context. I just wanted to, start the discussion.
Yeah, thank you.
So generally, what we know right now is that we have 14 prisons where we have no janitorial staff whatsoever to do healthcare cleaning. That is part of the why this program is going to cost a lot of money. In addition, some of the prisons where we do have janitorial staff, we only have 1 or 2 people that are assigned. Some of those people aren't even responsible or cannot, because of their classification, supervise inmates. So in looking at a future model that we think is sustainable, what we believed would be appropriate is to create a vocational program where you have CalPIA civil service staff oversee the training of inmates in each of our prisons, and in doing so, we're creating 1,000 inmate slots. This will be a CalPIA program that is present in every single facility in the state of California. It's the only CalPIA program where we'll have positions and programs across the board. It's also increasing the inmate programming by 17% by creating these slots. These inmates will go through a vocational program where they will be receiving a certificate for cleaning. That is something that they'll be able to use when they leave CalPIA and go out into the community. And it's also something where, in looking at the labor force, there is a shortage of people that can do this type of specialized cleaning in the workforce in general. It also has the support of SEIU. These inmates are going to be receiving 6 weeks of program credits, so it will also have a benefit of having a reduction in the inmate population overall. For all those reasons, we think that this is a really good proposal.
Thank you. And I have to tell you, I think the committee thinks it's a good proposal, too.
Yep.
Yes. This is exactly the kind of thing we want to see.
Yep.
Deals with a real problem in our prisons.
Yep.
And I'm assuming that you've checked and you know that this is, in fact, a job where a former inmate won't be disqualified in some way.
Actually, the CalPIA staff have already been in touch with the Department of General Services in terms of even having them work as state employees. And for many state buildings, this will be something where DGS and SEIU and CalPIA are going to be able to partner so that we have the workforce available. We've just started the pilot where we did this at CMF, but we've already had 1 inmate that was in the pilot that has paroled, and they have a job. So, that's just the beginning of what we see as the logical progression of 1,000 inmates during the year that will be able to benefit in this program statewide.
Yeah, no, I think that it really looks very, very good. We're going to hold the item open because we would like more information on how the $28 million would be spent. How much for custodial supervisors, how much for other staff, how much for CalPIA administration, how much on supplies and equipment, how much is due to the fact that we had 14 prisons with no health janitors. Hard to imagine. But and how much, but I think this is something we want to do, and if we get this information, we'll figure out how we can.
Yeah, we do
can
have
get
that
there.
breakdown, and we'll be able to share it with your staff and sit down and go through it.
That's great. We would appreciate that very much. Is there any public comment on this item?
Selena Pryor-Dansby with SEIU Local 1000. I just would like to reiterate our support for the CalPIA project. Thank you.
Thank you. Good. Any other public comment? If not, we'll hold the item open, but we're looking for the best and most cost-effective way to move it forward. Okay. Next, we have the pharmaceuticals augmentation, BCP.
So this proposal is for an adjustment to our baseline amount that we receive for pharmaceuticals for all of the drugs that we use within our prison system. And, you know, maybe to just speed this up, you know, we did look at the LAO recommendation about doing like a 2-year extension, and, you know, we would be good with that. Not only because there are definitely additional things that we can do in terms of saving money through additional efficiencies, but the cost of drugs fluctuate depending on what goes generic and what new drugs come on the market. So we think it's reasonable that, you know, we would want to look at this item again in another 2 years, and we're fine with, you know, doing a report to the legislature on this issue.
Great. Thank you very much. Any comments from LAO or DOA?
Yeah, we just wanted to add that we had recommended the receiver report on a couple of specific things. So one would be looking into additional efficiencies that they could achieve, and the other would be looking at evaluations that have been done independently of the receiver's pharmaceutical program and reporting to the legislature on progress they've made to achieving the recommendations in those evaluations.
Okay.
And we'll be happy to do that.
Great. And the central fill pharmacy is now implemented, and is it working?
Yeah.
Have we saved money?
The central fill pharmacy is up and running. We have saved money right now. So, Teresa, you want to? Teresa Kamara-Yip is our manager for Central Fill Pharmacy, and she can fill you in on generally what kinds of savings we're getting in terms of the operation.
Okay.